Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high-quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
This is Ike Ahmed.
And I'm Arsham Shaybani.
And we want to welcome you to GT, the podcast.
We're bringing this to you together with BMC and Glaucoma Today,
to offer audible insights into current topics in glaucoma care.
Presented by the authors of our latest, most read GT articles.
Check it out.
Welcome to another episode of Survey Says with Dr. Paul Singh. On this special edition of GT the podcast, Dr. Singh presents a real patient case from his practice and asks his guests to share how they would approach it. For this episode, Dr. Singh met with Drs. Manjul Shah and Tiziana DiFrancesco at the American Glaucoma Society annual meeting to get their perspectives on today's case. This case involves a pseudophakic patient with a history of high myopia and primary open-angle glaucoma. The patient previously underwent selective laser trabeculoplasty and placement of an iStent inject during cataract surgery. He is now on topical medications but has poor compliance and is experiencing significant dry eye, fluctuating IOP, and slightly progressive visual field loss. The group discusses the patient's treatment history and how it informs which procedures to consider for the future and which ones to rule out. They consider the role of topical medication in the treatment of glaucoma and how their approach to surgical intervention has evolved over time. Later, the guests find out what Dr. Singh did and how the patient fared, as well as how GT's audience chose to proceed based on the results of a social media poll. Tune in to Survey Says with Dr. Paul Singh.
Well, welcome everybody to another episode of Survey Says. I'm here live in person with two amazing friends and colleagues and guests. We have Manjul and Tiziana who are going to help me out and talk about a case.
Awesome.
A real case, actually, that I did. And I'd love to hear your thoughts, too, and kind of see if did I do something correctly or would you have done something differently. And that's the idea of this whole kind of podcast is talk about a real case and then what I did, but then talk about what you guys would do. And then also the cool thing about it is we survey the audience, both on LinkedIn and Twitter. We kind of see, okay, what are the people on the rest of the world thinking? What would they do? And kind of compare ideas as well. Because as we know with glaucoma, no right or wrong answer sometimes, which is kind of frustrating too as well. But I appreciate you guys hanging out. We're going to talk about a case. And this is a 72-year-old pseudophakic Latin American male with a history of high myopia, so 12 diopters before his IOL, so pseudophakic. Glaucoma about 15 years, had SLT about 3 times, had some effect the first 2 times, but not much the last third time. Had iStents placed nasally. They were in good position as well during cataract surgery. But now the patient's back on topical meds, actually 4 topical medications, and has significant ocular surface disease, so dry eye, poor compliance, and honestly the pressure's been up and down a lot, fluctuating. So I don't know if it's a compliance issue or other thing. We'll talk about that. So the visual field though has been progressing, and that's kind of the most important thing. Now the MD is about a -7. It started like a minus 2, so about 4 years ago. So it's kind of gotten worse in the last few years. So my question to you is not like advanced disease at all, but the patient's on topical meds and 4 meds. So I want to just kind of get your thoughts after hearing that history. First of all, does the history of SLT and failed stents tell you anything else about what's next, what you could do, and what the outflow is like and resistance? Talk about that, TC.
I would say when I see this history, this is a high-risk patient for me. This patient already, it's actively progressing, already had a Schlenz canal procedure, 3 previous SLT with not a great response, and is on MTMT and has a poor compliance. And also this patient is, the pressure is not on target. So we know this patient, when we're choosing a surgical procedure for this patient, we need to choose a procedure that it's gonna have the highest chance to reduce the IOP and try to decrease as much as possible the number of glaucoma medications. And for this patient, I see that there's no room anymore, in my point of view, for a Schlenz canal procedure. I do see this patient as needing more than that. And I would think about a filtering procedure. As we've discussed, this patient is previously high myopic, so we do have a higher chance of post-op hypotony. I would try to avoid going for a trab right now, and I would consider implanting a Zen 45 for the ab-internal approach, closed conj. I think we would be choosing a procedure with a high chance of achieving the target IOP and preventing post-op hypotony.
Well, nicely done. How about you, my friend? Can you add to that?
I think we're done.
I'm sorry.
No, goodbye. It's hard to beat. I mean, I think, TC, you're absolutely right. You know, I think SLT is a really great prototype canal procedure, right? We think about it as just a laser, but it's a Schlemm's canal procedure, and stenting is that to the next level. And, you know, we know that, you know, especially our smaller stents can be placed a little too deep or too superficial and not achieve the desired outcome. But quite frankly, the fact that they are placed by an expert surgeon who looks on gonioscopy to confirm that they're well placed.
I try once in a while.
And it worked. I assume it worked for some period of time.
Yeah,
right?
Patient was off drops for a little bit of time.
Right.
And slowly added them back on again.
Exactly. So you know that the canal has been intervened upon as much as one reasonably can, and to expect a really meaningful outcome difference from a bigger canal procedure, I think you're probably spinning your wheels at this point.
Yeah.
You know.
Do you think, back to that comment about SLT, and you know, SLT had some modest effect. Do you feel like when you have a patient who has SLT done and they don't have a great effect, do you think that tells you the resistance? Again, this is anecdotal, but that maybe the resistance is not at the level of TM, that it might be beyond. And we talk about this all the time, right? Do you think it has any diagnostic potential in your eyes?
I don't know, because I think both the positive and negative predictive value is too high, right? Because you can imagine someone for whom SLT just isn't enough to kind of bypass the whatever trabecular disease. And you can think of the person who has distal disease where the TM is now no longer the path of resistance, right? And you're just measuring IOP, so you're not going to know where along that journey the failure point is. The only way you would is by surgically intervening on the canal, which you did, right? Yeah. And it worked until it didn't.
Yeah.
And so I look at this person just like TC did, and we're thinking, that the physiologic outflow system is no longer sufficiently viable.
So let me ask you, now I'm a big fan of IG like you guys are, right?
Yeah.
I kind of look at this and I'm like, damn, man, I waited a long time, if a little bit longer until the patient progressed a little bit before I said, let's do something more. So let me ask you guys, and we talked about this before, what is your definition of MTMT now? Like, that's something that it's been evolving.
Yeah, sure has.
In my practice. Talk about that, Shoshana.
I think I've changed a lot in the past years. I've been a little bit more aggressively when deciding to intervene. And before, I had a tendency to add a fourth glaucoma medications, maybe for my kind of like, for me and for my mind,
almost, right?
for treating me and to kind of like to tell my patient, okay, we tried as much as we could, but right now, if my patient is on 3 glaucoma medication that's progressing, I don't need to add a fourth medication to decide to go for surgery.
Yeah, and I mean, I think we have to consider not just the number of medications, although the number of bottles, the number of drops being placed on the eye, the frequency.
And the compliance of the patient, right, is a sport.
As you go up on the number of bottles or the number of distinct episodes of installation, your compliance is going to drop. And your side effect profile is going to go up. And I see this patient who not only is on a lot of meds, but they're also experiencing the negatives of being on a lot of meds, right? You're seeing it every day. And Paul, you are second to none in terms of harping the importance of assessing the ocular surface in our glaucoma patients, right? I mean, we beat these eyes up. And we're not doing we're not doing right by them if we are.
And that's why I look at this, I'm like, man, I should have probably intervened earlier. Right now I talk about it all the time, like, but the fact that the patient was probably not compliant, from I remember, even after taking like one drop, you had a second or third, you're pretty much not going to help as well. So last thing I'll say is on this before we get into the results, dry eye. Do you feel that you have patients who have ocular surface disease, that it's not just a compliance issue, that there might be a level of trabeculitis? Do you think there's like an inflammation going on that could cause patients to have poor response to drops? I'm curious, your thought process on that.
I think there's a lot of unanswered questions in how, in just the MOA of how drops make it to the end organ, right? So like, we see this clinically, right? Like theoretically, drops should work about the same in different folks, but we see wide
Very
differences,
variable
and
results,
we have patients who are just super responders to beta blockers, or super responders to CAIs, or non-responders to PGAs, and everything in between. There's got to be something going on, and we see this in some of our newer sustained drug delivery technologies, where when we bypass the whole ocular surface, put the medication in the eye, we don't just get parity with the topical agent, we do better. How is that possible? It's just a molecule.
Or maybe it's just compliance.
Yeah.
Right.
We don't know, right?
Compliance
Yeah.
or absorption,
Yeah.
I'm curious because I've seen a lot of patients who we treat the dry eye, and for some reason their pressure comes down, or they have better responses. You wonder, is it inflammation? Is it compliance? So just curious on that, but definitely
Yeah.
don't ignore the ocular surface.
Totally.
That's the bottom line.
And a prototype of that is a brimonidine allergy patient. When they show up and their eyes look horrible and their pressures are up, and you stop the agent and everything comes down.
Yeah.
Right?
I'm so glad you brought that up. Last week, I had a patient with brimonidine allergy. Guess how high the pressure went up to? 52.
Yeah.
Oh my God.
52. Tapped him and brought him down, came back. I put him on steroids, actually,
Yep.
retinol.
Yep.
Came back down, pressure down to 21.
Exactly.
And so, absolutely right. That's the extreme example.
It's an extreme,
Yeah.
but it's
Really-
a prototype. That's like
really
that's
good.
the thing to burn into your brain.
Absolutely. Great points, guys. Well, let's talk about what I did. So, wait, actually, I didn't ask you, Manjul. So, you also wanted to do a
I would probably go with
subconjugated?
with a subconj procedure, and I think for the reasons TC nicely outlined, high myope, ocular surface that's not in the best of health. I think a small, like a Zen, would be where I would go with also.
And that's what I did.
Nice.
So I followed your
Okay.
commands, everybody. So I did open conj,
Okay.
superior nasal, and surgery went really well. Pressures came down pretty nicely, like they should. Single digits the first day, and then a week later, kind of up to kind of 10, 12 range. But then, I think patients' compliance was not very good, and I do think that probably contributed to the fact that eventually it did scar down, and I did do a needling and revision, and just kind of did not work as well as I wanted to as well.
Okay.
So, any thoughts on open versus closed conj real quick? Just because I know you guys you mentioned closed conj. Are you a big closed conj fan for?
It
Zens?
depends. It depends of the type of patient that I'm dealing with. If I'm dealing with a younger patient with a more thick tenon, I do prefer to open the conj and make sure that I know where I'm placing the Zen. But if I'm dealing with a patient that is older, that the ocular surface is really well preserved, then I'll go for closed conj. That's how I usually decide if I go for open or close.
Yeah, I mean, I think the nice thing is you can do it both ways, and we have good studies that show that both work, and both can work really well when you optimize it, right? So really making sure that you're not in tenons. As long as you're not in tenons, open versus closed is all good. I am still a primarily closed conj guy and I do a primary needling.
Love that, man. You talk about it.
And that way, I don't have to do a peritomy, and I have that sort of control of the distal aspect of the Zen where there's no tenons around me.
Any advice on how to maximize the surface? Like in this kind of patient, I didn't really take the time to maximize the surface as much as I want to. Do you think that played a role in failure? Doing dry eye and all those drops?
I'm sure the patient's inability to keep up with their postoperative regimen played a role. But if they're walking in inflamed and then they're not treating the inflammation postoperatively, then you kind of are set. But
when the conj is angry and not happy going
Right.
in, it definitely is a high risk. So I try to put some people on Diamox and then take
Totally.
them off a drop.
and then
Even put like a Durista or something in there if I need to.
And to your point, Tiziana, that fourth molecule is probably not doing much.
Yeah, and oftenly I just stop the fourth glaucoma medications. I put patient on steroids 1 week before surgery, QID. That's what I usually do for my future procedures.
Yeah, and it's not the worst thing in the world to do an interval pressure check just to make sure that the medication you stopped is
not
causing them to
affecting,
spike or something odd.
And to help with compliance, I had him on a combo, latanoprost and Tarsadil,
Yeah.
and a brimonidine, or brinzolamide combo, right?
Yeah.
So it's 2 bottles, but it still was hard for the
still-
patient.
Yeah.
It still caused a lot of
Yeah.
issues
Still-
as well. So what do the audience out there say? Well, on Instagram, most patients, or most docs rather, picked the same thing, a MIB/TRAB, about 50%. And it was split really between GAT and then a tube. A few people said CTC, but mostly maybe half said MIBS TRAB. And on LinkedIn, it was really the same idea. About 50% said a MIBS TRAB, and then it was kind of more tube shunt and then GAT. So definitely the subconj world won, which is important. But I'd love to hear your thoughts now, though. If I tell you that the patient's Zen didn't, probably the patient issue,
Right.
kind of scarred down despite needling and 5FU and revisions. So with that said, patient's back on drops, pressures are back up again.
Yep.
What's next for this patient? We can do a lot of things now. What are your thoughts now? So we have a superior temporal conj, still looking good.
Yep.
What do you think?
Consider that the patient was a previous high myopic, I would still continue in the MIBS options. So I would go for the PrismaFlow, but I would use a ripcord. I would use a 9/0 nylon and use the ripcord and keep it at least for the first week to prevent post-op hypotony. And we could consider a trab as well. However, the study shows that we have double the rates of hypotony when comparing PrismaFlow versus trab. So I think for this patient, I would try a PrismaFlow. In my hands, I feel that I can achieve a lower IOP, a final lower IOP with PrismaFlow compared to Zen, and that's what would be my choice.
So we can send all our patients to TCI because we don't have PrismaFlow, man.
We are now the United States.
I know. I'm sorry. I'm spoiled in Brazil.
I know, yeah.
It's not fair.
Get a PrismaFlow and a round trip ticket. What's the cost? Here's your opportunity. You get a little medical tourism.
I know, man. There you go. Not bad. Not bad.
With what we have now, I agree, Tiziana. PrismaFlow does provide some value. Especially in these folks who are scars, right? Because the SIBS material may mitigate some scar formation. You're doing an open dissection by definition. But my concern is this patient did eat through a MIBS procedure. And the failure point is still kind of the same. It's in terms of conjunctival scarring and episcleral fibrosis and those things that are going to be the case regardless of MIBS technology, typically. Maybe they just need a little bit more anti-metabolite to get them over the hill, but when I see this sort of story, there's a few things that I cross off the list. I cross off, again, despite your best efforts, the Zen failing, I cross off microfistulas, and I also cross off trabeculectomy, because the failure, assuming, again, we did a nice placement, we needled it, etc., they still are crashing down on us. The failure point of a trabeculectomy is going to be the same. So I'm moving essentially directly to tube shunts at this point. And especially this individual who's had, antimetabolite placed, mitomycin, 40 to 60 micrograms typically at the time of Zen placement, some 5-FUs afterwards, maybe even another dose of mito if you needled them. That's a lot of antimetabolite. Even though that supratemporal tissue looks normal, it often doesn't behave normal. And so this is where, again, I like shunting with tube shunts, and I typically go valved here because these are patients who may not form the kind of robust capsule we're used to. And if you go non-valved, you can be surprised on the low end with some hypotony.
What about something like a CPC?
It's interesting, but this is still someone who has outflow dysfunction. I really am biased towards optimizing outflow before I start to mess with inflow. And another clue, it's a correlate, and it's not a real, it's close. They're on aqueous suppression, right? They're on pharmacologic aqueous suppression, and their pressure's nowhere where it needs to be. So CPC is surgical aqueous suppression. I'm not expecting a huge difference between my CPC result and them on MTMT. But then again, once we have established outflow, now we can turn down the faucet and get a meaningful result.
Oh, it makes sense, absolutely. Yeah. Well, let's great points, guys. Let's see what the audience said. So for the Instagram world, it was definitely favored trabeculectomy. 50% said a trab.
Go big or go home.
Go big, man. The trab still worked, though.
Yeah.
And then a tube shunt was 40%. So between those two, it was pretty much 90% of what people thought. And a CPC and another MIBS was definitely lower. In the LinkedIn results, it was actually a little bit more skewed towards what you were saying, tube shunts. And non-valved or valve, we didn't differentiate, and then trab, and then there was a little bit more another MIBS / Zen kind of procedure as well.
Sure.
So, quick for you, I'll tell you what I did in a second. But from a tube shunt perspective, have you guys had any experience or heard about some of these newer tubes like the Paul shunt in Europe, or now in America? I think New World has the new ClearPath ST coming out. I've tried one of those. Any thoughts on those smaller tubes, non-valve tubes?
So the reason we have tubes of the lumen we have is just antiquated. It was a manufacturing constraint from decades ago. That's the only reason. There's no actual physiologic reason to have a 300 micron lumen tube. It just doesn't make sense. And having a bigger object in the eye is probably not awesome, and having no resistance to outflow is probably not awesome. So I think these small lumen small diameter tubes are, quite frankly, how we have to do things. There's just no reason to continue doing it the old way. And it opens up a lot of possibilities in terms of how you want to flow restrict. You can just simply, as opposed to worrying about exact suture tension and ligature, you can actually just simply stent these small lumen tubes with 6-O-proline, for example.
Yeah.
So it's a long time coming. It's a necessary thing for our space, and I'd like to imagine that when we're having this conversation 5 or 10 years from now, there's no one putting in big lumen tubes anymore. All tubes have just
The corner would be happy too.
Exactly.
But Tiziana, have
Yeah,
you
and I
any
agree.
thoughts?
And you have a bigger lumen size that increases the risk of hypotony. But actually later on, we know that one of the biggest reasons for failure is the resistance around the plate, right? So the fact that you're having a bigger lumen doesn't usually help.
Yeah.
It just increases the rates of hypotony and doesn't help later on long term.
It's all bad and no good.
Yeah,
And we figured out ways to
that's it.
jerry-rig these bigger tubes to make them work for us. But that's what we're doing. We're just tinkering.
Trying to figure
We're just
it out.
trying to make a suboptimal technology work.
Yeah, I actually I tried the new ST,
Yeah.
the ClearPath, and so yeah, I mean it was kind of interesting. It came with a ripcord, so I didn't ligate it. I think that's a big step that people don't like to do is ligate, and so I just tested the flow. It wasn't significant with that ripcord in there, and because it's a smaller lumen, I just kind of placed it without any ligation. So patient's doing pretty well, but it's an N of 1. So
Sure. Yeah.
for whatever that's worth.
Yeah.
But I mean, I think there's definitely a role for those newer plates as well. And the other thing too, there's another product too that I tried recently, which is another subconj device called Aqualumen. Just got approved and by a company called PLU Ophthalmic. And what it is basically a 23 gauge needle that goes into the anterior chamber, like a transconj Zen almost.
Okay.
But basically you enter 2 millimeters back, so enter 10 millimeters behind the limbus at the conj. Then you engage the sclera at 2 millimeters behind the limbus, go into the AC, and then it has a little cutout in the needle itself in this device. So you just move to the left and then kind of come back, and it does a core. So it cores out a strip in the sclera.
And it creates a
A tree fine,
sclerostomy.
so that's another way to consider at least doing a subconj. So I think we're seeing a lot of products coming out because as much as we love our MIBs and MIGs rather, I think the MIBs world and subconj world I think is gaining attraction. And because we realize MIGs is great and it does buy us time, but in some patients we still need a subconj surgery as well. Last thing I'll ask you guys, CPC. When do you guys do CPC and when do you do it? Because I get a lot of questions from people. How do you do CPC and when do you do it?
I tend to leave CPC for the patients that already had at least 2 filtering procedures. And the reason for that, I think, is the unpredictability of the results. Sometimes you just do the same laser parameters for patients and then you have a huge hypotony. And the problem is you don't have much what to do to reverse that hypotony. So I'm a little bit cautious with CPC. And I really reserve for patients that had a really, really high risk of failure doing another filtering procedure.
Yeah, my use case for CPC is classically in patients who are failing tube shunt number 1, and we're at the decision point of do we place a second shunt or not. And there was a small but decently the approach was decent and a prospective RCT looking at second shunt versus CPC. It ended up being underpowered because recruitment was during COVID. But in the very limited sort of follow-up that was limited N that was realized, the outcomes were very similar between placing a second shunt and a CPC. But certainly CPC has some benefits in terms of it's just faster. Less patient discomfort, less post-operative visits required. So again, my use case is post-shunt if we need further IOP reduction. If we're going into the OR to do cataract surgery in someone who's post-shunt, then I might just elect to do an ECP because I have that much more control. But someone who's suboptimally controlled after shunt and we don't have to go back in, that's my prototype CPC patient.
Because I did CPC in this patient.
Okay.
Not unreasonable.
We're curious. How
That's why I'm asking.
How did it go?
No, I think another trab or a tube or another MIBs all are appropriate, which is why it's no right or wrong. But I did triamcinolone.
Did you feel like the conj was not good to do the
the
secondary?
conj, to your point, the conj is not great. He's a high myope, so for a tube, and patient was also squirmish and just wasn't compliant. I was like, let me just do a C. So we'll see. It's only been like about a month and a half. So I mean, so far he's doing pretty well, but back on one drop. But I think it's doing okay so far. But I think he might need something again. So I might have bought myself some more more time
Yeah.
to figure stuff out.
And
as
the
well.
consideration now that he's had cyclodestruction is what tube do you want to do? Because
Yeah.
now the
What you're
floor
saying,
is
now
much
the floor is
lower,
Yeah.
right?
Exactly.
Yeah.
There's where
Yeah.
the small tube might be a nice option. And
Exactly.
I get that too
Exactly.
in case as
Exactly.
well.
Yeah.
But this was awesome, guys. I wish I could hang out more. I learned so much from you guys. This is why I do this, because I get
thank
stimulated.
you.
Like I'm ready to do more stuff. This is
Let's go.
really cool.
Let's go CPC everyone.
Let's go see everyone. No, but man, this is awesome.
Moral of the story.
Exactly. But no, thank you, Tiziana.
great.
Thank you,
Thank you so
Manjul.
much.
Thank you, everybody out there who will hopefully is listening to this episode. Hopefully, we'll have another Survey Says coming your way. But until then, have a good time, stay healthy, and see you guys soon.
Take care, you guys.
Thank you.
Take care.
Great hanging out.
Thank you.
Thank you for tuning into this episode of GT the Podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.